Dr. Wachtel for the kind introduction. It's really a treat and a pleasure and an honor for me to deliver the Thomas Wachtel lecture. I've known Dr. Wachtel for a long time. He probably doesn't remember this, but I got to meet him the first time when we had one of our Trauma Medical Audit Committee meetings in San Diego, which we held every month and have held for 28 years, where we do quality improvement countywide. And Dr. Wachtel was the trauma director at one of the trauma centers in San Diego, Sharp Hospital. But he started in San Diego in the burn unit, which is now part of my division. So I'm very pleased to be introduced by Tom and to see him participating in this conference. I decided to talk to you about something that is important to me, that has been important for our trauma system in San Diego, and something that I've been on a crusade about, because I think that until recently, many of us didn't pay attention to this issue of pre-injury anticoagulation. I have no disclosures. Before I start talking about pre-injury anticoagulation, just want to give you a couple minutes of explanations and presentation where I come from. This is, I come from UC San Diego. The building that you see on the right side is called the Geisel Library. It's not the biomedical library, but it's such a wonderful building that led to the UCSD logo. It's based on the Geisel Library. We are split between two medical campuses at the University of California, San Diego. You know, the campus of the university is in the city of La Jolla, 12 miles north of downtown San Diego, which is a beautiful beach town where most of the rich people in San Diego County live. And we have a very vibrant medical campus in La Jolla, as you can see in this picture. Right upper corner is General Hospital. It's called Thornton Hospital. Next to it is our Eye Shiley Center and the Glaucoma Center. Down there is the VA Hospital. And this is a relatively new NCI Cancer Center, the Moores Cancer Center. In addition, we just opened a cardiovascular center in La Jolla, and this is a hospital that's being built as we speak and will be done in 5 years. It's called the Jacobs Medical Center. Mr. Jacobs is the owner of Qualcomm, and he was a UCSD student, alumni, and has given a tremendous amount of money to the university, including funding the School of Bioengineering, has given to the School of Medicine as well. And this apparently is going to be the most advanced hospital in America when it opens. It's a green hospital, and it's called the Hospital for the Future of Surgery. This is all great. Unfortunately, I don't work in La Jolla. I work in the other campus, the poor campus. It's called Hillcrest. It's an old neighborhood in San Diego. I won't tell you what Hillcrest is known for because it's not politically correct, but it's an old neighborhood close to downtown where our initial medical center was, which was the county hospital. And when the university opened the medical school, they bought the county hospital. And that's where the trauma center and the burn center is. So that's a view of the UCSD Medical Center in Hillcrest, where I work. And I'm showing this picture because some of you in the audience have been there and know that this green building is the trauma offices. So it's a bunch of apartments that we call this building Crack House or Melrose Place. It depends if we're in a bad mood or in a good mood. But I got a corner office because I'm the chief there, so this is my office. And that was Dave Hoyt's office, so there's nothing wrong with it. But that's UC San Diego. A little bit about our program. We see about 3,000 patients a year, 380 major burns. This year we'll probably top 425 major burns. Last year we did 1,100 emergency surgery operations. We have 2,200 ICU admissions. All this work is done currently by 7 full-time faculty, 2 fellows, and 3 physician extenders. So I'm going to review with you today the problem of pre-injury anticoagulation, talk a little bit about the methods of reversal, and discuss the benefits of PCC in trauma and other surgical conditions or prothrombin complex. So you heard this morning what the problem is. The problem is that the population is aging. More active elderly individuals are presenting to trauma centers because they want to get around, they want to drive, they want to travel, they want to have an active lifestyle, and therefore they're more exposed to injury. But they bring with them to our trauma centers a long list of comorbidities and a bag full of medications. And one of the classes of medications that they commonly take are anticoagulants or antiplatelet injury, agents, and therefore we have to deal with this problem on a daily basis. So just briefly, aspirin and non-steroidal anti-inflammatory drugs, although we don't think much about those drugs, we don't think that they have a significant impact in what we do on a daily basis, it's important to realize that aspirin and non-steroidal anti-inflammatory agents, they affect the coagulation cascade and they induce bleeding by different mechanisms. The drug that we are seeing more and more causing problems to trauma patients, and we talk a lot about it, although we don't know what to do with it, is clopidogrel. And people that live in California know how to say clopidogrel. But we can say Plavix, Dr. Crouse. But anyway, we know that clopidogrel inhibits platelet aggregation. Yeah, it's not easy. Inhibits platelet aggregation and prevents glycoprotein 2B3 activation. The bottom line is that after 7 days, Plavix reaches its maximum effect at 40% to 60% platelet inhibition. And when you stop that drug, it takes about 5 days for the effects on platelet aggregation and bleeding time to normalize. So by just stopping the drug doesn't do the trick if you have an intracerebral hemorrhage. I'm going to present to you a series of papers, and the way I set this up is you see a positive or a negative sign. So if you see a positive sign on the slide, it's a positive study that supports the concept that these drugs are dangerous. And if it's negative, the study was negative. But this one is a study on patients on antiplatelet therapy prior to their trauma. And the bottom line is that although they didn't find a significant difference in mortality comparing patients on antiplatelet agents and not on antiplatelet agents, they found the craniotomy was associated with a 2.6-fold increase in mortality. So if folks that need an operation, they die more often if they are taking antiplatelet agents when you compare them with the overall population. This is another study that looked at aspirin, ibuprofen, and naproxen. And the data indicates that elderly patients on antiplatelet therapy are in fact at increased risk of life-threatening intracranial hemorrhage. So you know this is not new. This is a negative study that shows that there is no difference in mortality. But when you look at the studies, they are all retrospective, small series, and it's hard to interpret and to make sense of all this data. This is another positive study that looked at aspirin, Plavix, or Plavix and aspirin, which we see quite often. And again, 23% mortality in the antiplatelet cohort compared to 9% mortality. So there is some signal in the literature that these drugs are dangerous. So we know about those things. When the studies don't show a difference in mortality, they show a difference in complications or incidence of need for craniotomy or incidence of rebleeds, etc. So there is some indication in the literature that they are dangerous. The problem is that we don't have a good strategy to deal with those patients, and the reversal of antiplatelet therapy hasn't been well defined. These are the strategies. You can give platelets, you can give DDAVP, or eventually you can give recombinant factor 7A. Now, are there studies giving these drugs in trauma patients? They're not. They're a small case series, and we don't know if the therapy that we implement when these people come to the trauma center is effective or not, because we don't have a good way to measure platelet inhibition and the response of platelet inhibition to the therapy that you're giving. So there is a couple assays out there. One is known as the PLAVIX assay that you can measure platelet inhibition. We did a study. The numbers are all over the place. It varies from individual to individual. But even if you believe in the results of that assay, the assay doesn't tell you when you give platelets whether or not you reverse the initial effect of the drug. So really, we have an assay. We don't know what we are measuring. And even if we believe that we are measuring what we are measuring, we don't know if it affects the therapy. So it's a mess. And we really don't know. There is very little data on heparin, low molecular weight heparin, fondaparinux. But at least heparin we know how to reverse. There is an antidote. Low molecular weight heparins and fondaparinux. Currently, there is no drug that works as an antidote that's approved by the FDA. Now, Plavix, aspirin, we see this often enough, but it may not be a big problem. But the real problem is warfarin, right? So major bleeding is common after warfarin. The incidence of major bleeding is 6.5% per year. So it's not negligible. And we see a lot of those elderly folks taking warfarin for a number of reasons, AFib being the most common, coming to the trauma center with significant injuries and eventually traumatic brain injury and intracerebral hemorrhage. The fatality rate's 1%. In all ages, but it's much higher in the population that's 65 years or older. And obviously, the most frequent cause of death in patients taking warfarin is actually not a complication of their AFib, stroke, or heart attack, but it's intracerebral hemorrhage. And patients that are taking warfarin and bleed in the brain, they have an incidence, a mortality rate that approaches 60%. So it's a big problem. It's a big deal. So the problem is that warfarin inhibits factors 2, 7, 9, and 10, and we need to have a very good strategy to reverse those individuals quickly, but more importantly, to identify those that are at risk when they reach the door of the trauma center. Now, a couple words about atrial fibrillation, because you're going to get a lot of pushback from your cardiologist about stopping those drugs for patients that have atrial fibrillation. So atrial fibrillation is a problem. 5% of patients over 65 have it. 10% of patients over 80 have it. And there is no question that patients with atrial fibrillation are at a very high risk for stroke, and the treatment is anticoagulation rate control. There's actually even a score for atrial fibrillation, right? The CHAD score. But I look at this not as a cardiologist, but as a trauma patient, and look at what the treatment is according to the CHAD score. Aspirin, if your score is very low and your stroke risk is very low, but if your score as your score goes up and your stroke risk goes up, you need to take warfarin. So warfarin is really the problem. So the cardiologists will say that warfarin atrial fibrillation patients saves lives. And actually there are some studies that show that for those who took warfarin for 1.5 years that have AFib, 96% saw no benefit, 4% only were helped preventing one stroke, 2.4% were helped by avoiding a death, and 0.26% were harmed by intracranial hemorrhage. So it's the double-edged sword. So in other words, 1 in 25 that take warfarin and have AFib are helped, 1 in 42 helped preventing death, and 1 in 384 harmed by intracranial hemorrhage. Now, when you read this literature, it gets confusing because, remember, studies have study patients. So what happens to study patients? They sign consent, they go to the Coumadin clinic, they have their anticoagulation well controlled, the warfarin's adjusted weekly or biweekly. They are not fall risks, otherwise they're excluded from the studies that the cardiologists do. and they are usually younger. Very few patients are 75 or older in the cardiology literature for this matter. And the studies have a short-term follow-up, 1.9 years. So the reality, though, is that from a trauma surgeon's point of view, the mortality rate associated with intracranial hemorrhage varies according to a few things. One is the neurologic status of the individual as they hit the door of the trauma center. And two is the degree of anticoagulation. So according to the neurologic status as they hit the door, if your patient is unconscious on admission and is taking warfarin, 96% chance of death. If your patient is unconscious before the beginning of the active reversal, 80% chance of death. Now, if your patient has a normal level of consciousness prior to the beginning of the reversal, mortality drops to 28%. So it's the neurologic status upon admission that affects outcome, but also how quickly you start your reversal. So a number of warfarin trials have been published. Some are negative, some are positive. But invariably, when you look at positive trials, and I'm going to go through these very quickly. You don't need to learn all this, but just look at the INR numbers. 3.5. Increased mortality, 40%, 20%. 40%, 8%. 87.8%. I'll discuss this study with you in detail. But look at 4.9% in control, 24% in warfarin. Now, if you add taking warfarin and an elevated supratherapeutic INR, mortality goes up by several fold. So again, people will die if they have an abnormal level of consciousness as they come to the trauma center. They will die more often if they have a supratherapeutic INR, second factor. And third, if you delay immediate reversal. So 3 factors that we need to take into account when we think through this problem. So the summary of all those trials show that there is a trend towards increased mortality in patients taking warfarin, regardless of their injury severity. And premorbid warfarin may convert a relatively benign head injury into a disaster. That's what we get when we read those papers. But we also learn by reading those papers that the admission INR is very important, because if it's supratherapeutic, patients will die. It increases mortality by several fold. Now, we were concerned about this, and in 2005, so not long ago, 7 years ago, we were seeing more elderly patients coming to our trauma center with devastating injuries, and we decided to ask trauma surgeons in North America if they were finding the same things, if they were concerned, and if they were concerned, if they had a strategy to reverse those patients. So this is a long survey, was published in Journal of Trauma in 2005, but I'm just going to show you 2 pieces of data. The graph on your left is the answer to the following question. What's the INR level above which reversal of anticoagulation is implemented in your hospital? These are 100 trauma directors of level 1 and 2 trauma centers in North America in 2005. And you can see the spread. Some people said 1.2, some people said 1.4, some people said 1.6, some people said 2, and there's always a guy that hates surveys that said greater than 7, whatever. This guy on the right side. But you see the spread. People just did not know. And I don't know if they didn't know because they didn't think about it, they were not seeing what we were seeing in San Diego, which I doubt, or if this was not a relevant problem at the time and just became as the population aged. The graph on the right answers the following question. What is the target INR that you consider that you achieved reversal of anticoagulation. So let's say somebody comes in with an INR of 3.5, you start reversing. What's your target INR? They just say, okay, reversed, stop. And you can see the spread again. 1.3, 1.4, 1.5, 1.6, 2, 3, 4 to 6, and that guy again 7. That's fine. But the spread is huge. This is just 7 years ago. So people were, in my opinion, people were confused. They just didn't know. So I came across this study, and I think this was, like Jim said this morning, there is always an index case. This was an index study for me because we had to rethink the whole strategy in San Diego County for our trauma system after this study came out. This is a study that they want to determine the effects of pre-injury warfarin on outcomes in elderly TBI patients. So they initially looked at 49 patients. They had a GCS score of 8. Mean was 4.7. 100% of those 49 patients had an abnormal CT, expected. Mortality was 88%. And those that didn't die were in a chronic vegetative state. So bad injury, bad combination, bad outcome. Interestingly enough, the INR was 6.5, and it ranged from 2.8 to 14.6. Now, how ridiculous is this? An INR of 14. There are a bunch of people out there walking the streets of Phoenix that have an INR of 10 or 12. And those are the guys that are going to come to our trauma centers. So, again, remember, the INR on admission is one of the most important factors related to outcome. What it tells me is that these people are getting those drugs and nobody's watching them. This is bad control of warfarin-induced coagulopathy. Now, mortality was, then they look at another 77 patients. They had a mortality rate of 80% with a GCS score of 13. Now, this group came to the hospital. They were talking just about GCS of 13. They were taking warfarin. The INR was 4.4. Mortality was 80%. This group came in with a GCS of 8, mean 4.7, and mortality was 88%. So there is not a huge difference in mortality because they were both super therapeutic, taking a dangerous drug. It turns out that 20 patients in the study were seeing the emergency department because they walked to the emergency department, they were talking, they were normal neurologically, or at least clinically, and they were sent home. No imaging in a significant number of those 20, and no further investigation. They didn't bother to check their INR. They had hit their head, lost consciousness, but they were normal now. Taking warfarin, nobody cared. Go home. It turns out that 18 of those 20 patients came back to the emergency department with significant changes on their head CT the next day, and 88.8% died. So you go to the hospital today talking, you're seen by a doctor, you're sent home, tomorrow you come back, and you die. That's the reality of what's going on here. And unfortunately, only 35% of those 20 had imaging done. So it is a problem. It is a problem of awareness. It is a problem of knowledge. It is a problem of putting these people in the front of the line to be treated and reversed immediately. So that's the problem. This is a real patient that I saw not long ago. That's the CT, initial CT, INR was 8. How do you deal with this? What do we need to do? What are our options, and how we can reverse this quickly? So the options for reversal, the classic options are listed in the slide. As you all know, plasma, vitamin K, recombinant factor 7A prothrombin complex, or a combination of all those strategies. Plasma has a problem related to the time it takes to thaw. Even if you have thawed plasma in your ER, you are not going to have enough to reverse an INR of 8 or 10, so it takes time. And there is the issue of volume, and most of these folks have comorbidities. They have heart failure. They cannot take 8, 10 units of plasma, so it becomes a problem, and it takes time to reverse. So it's not immediate reversal. Vitamin K, is a great adjunct. I would say to you that you've got to be very careful in patients that have mechanical heart valves because it takes a week or 10 days to re-anticoagulate them when they can after you give vitamin K. So again, it's a double-edged sword. We don't give vitamin K to everybody in our trauma center until we determine that they don't have a mechanical heart valve. Then there is recombinant factor 7A that really corrects INR very quickly, controls bleeding effectively, and the neurosurgeons like to use the term bloodless operative field when they use factor 7A. So it's a good drug. The problem is that correction is only partial and temporary, and there is a known thromboembolic risk, as you know. But what I want to bring to your attention is that the response when you use factor 7A is dose dependent. So this is a study out of shock trauma in Maryland that shows the factor 7A dose on the x-axis in time to reverse coagulopathy to INR less than 1.4. And as you can see, the higher the dose, the faster is the reversal. So there is a direct relationship between the time it takes to reverse and the dose that you use. So in that study, INR was corrected immediately to 1.3 or less, which was the target of the study, and maintained correction for 12 hours. Now, if you use the usual dose of factor 7A, 1.2 milligrams, the reversal only is maintained for 3 hours. So after 3 hours, you've got to do something else. Maybe give plasma, maybe give another dose if they are still bleeding. So although you achieve your goal immediately, it doesn't last very long. And that's the problem with factor 7A. And also, patients need supplemental FFP transfusion in the next 24 hours, as well as vitamin K. So this study asks the following questions. Do we need to give more than one dose of factor 7A if those folks go from the CT scanner to the operating room, from the operating room to the ICU, and they are still bleeding or their INR hasn't been corrected appropriately? Now, prothrombin complex concentrate is a source of all 4 vitamin K dependent factors in most preparations. In some, they have at least 3 of the 4 vitamin K dependent factors. Some also contain protein C, Z, S, antithrombin 3, and eventually a little bit of heparin. It's a good drug. I learned about this several years ago when the neurosurgeons at San Francisco General were very excited that they were reversing TBI-induced bleeding with prothrombin complex because it was a lot cheaper than factor 7A. So we decided to do the same at UCSD. This is a list of all prothrombin complex concentrates that are available in the world. Don't bother trying to read this, just to give you an idea of the number of drugs that are out there. Unfortunately, there are only 2 and now 3 available for clinical use approved by the FDA. But as you can see, it has factors 2, 7, 9, 10, and a few other things. So it makes sense because the drug is designed to reverse warfarin-induced coagulopathy. So it makes sense. If you take a drug that inhibits all 4 coagulation factors, you replace those factors. So it makes sense. Now, does it work? So the clinical studies on PCC, they all show that it reverses coagulopathy by decreasing INR to target levels very, very quickly as factor 7A or faster. The problem again is what is the duration of what's the duration of that effect? So as you read through this, I can leave you with all this reference, but the bottom line is that this drug works faster than factor 7A and for a much more prolonged period of time, and it's a lot cheaper. So it made sense. I'll show you that it works not just for a traumatic brain injury. This is a study that I like to quote because they used escalating doses of prothrombin complex based on the initial INR. So people were really thinking about this. So if the INR is 2 to 3.5, they use that dose 25. If it's 4 to 6, they use a higher dose. If it's greater than 6, they use a much higher dose. And so it makes sense because it replaces all coagulation factors. Can be used in a number of surgical conditions, cardiac surgery, CABG, valve replacement, other types of surgery, and obviously in warfarin reversal in general. What it shows, though, is that when you use prothrombin complex, you need a lot less FFP, you need a lot less red blood cells, you need a lot less cryo, and you need a lot less platelets. So this seems to be the drug that we should be using in trauma centers to reverse those patients that need immediate reversal on the way to the operating room from the CT scanner when you see a CT just like the one I showed you. And this is just to show to you that the duration of the drug is much better than the drug effects, much better than factor 7A. You can see that each coagulation factor measured after you give prothrombin complex lasts for about 48 hours. And on this side, on your right side, you see the mean INR was 1.1 30 minutes after giving the drug in patients that had INR above 4. And so the reversal is immediate, and it lasts for a prolonged period of time. So it seems that this drug makes sense. We have two drugs available to us at UCSD. One is called FIBA, and the other one is Profil 9. So those are the two approved for clinical use in the United States. They are very similar in terms of price, dosing, strategy to use. But what's important for you to know is that each unit of FIBA or Profil 9 has the same factor 9 activity as 1 ml of FFP. So if we use, for instance, 2,500 units of prothrombin complex, it has the same effect as 2.5 liters of plasma or FFP. So for those patients that can't take that much volume, this is fantastic. Now, we talk about taking the drug, looking at the initial INR, and then quick reversal, and the strategies to reverse. But the problem is you have to develop an institutional protocol. This is an example of an institutional protocol. They develop in their emergency department, level 1 trauma center, what they call the COHEN protocol. And the concept was very simple. They said, we got to have a mechanism by which we look at those patients upon admission, and if they are on warfarin, they go to the front of the line. They don't wait. They go immediately to the front of the line. They will be seen by a physician in the emergency department immediately. They will get a CT scan as soon as possible, and they will be reversed as soon as possible. So after they implemented that protocol, they identified at-risk patients very quickly, 19 minutes. They improved their time to CT from 130 minutes regularly to 85 minutes. So that was an improvement. But unfortunately, they failed to reduce the time to INR reversal with vitamin K and FFP. That's the strategy they decide to use. So again, 3 factors contribute to outcome. They fixed 2, but they didn't fix the reversal, the quick reversal one. So they thought about it, went back, and amended their protocol. So this is what a true quality improvement process is all about in trauma. They look at their results, they didn't like it, and they said, let's do better. And they did better. They improved time to CT interpretation. They facilitated the administration of FFP, and they gave vitamin K quickly. And they admitted patients for observation that had a negative CT as well, because those patients may have a positive CT later on. So these are the results. Remember, they went to 19 minutes to identify. They drop it to 14. Time to CT scan, 135 minutes to 85 minutes in the first phase to 42 minutes in the second phase. And they identified those patients that had progression of their bleed. 40% initially dropped to 11%. So this is very important because it's not just knowing that they take Coumadin, but knowing what their INR is immediately, reacting immediately, scanning them immediately, and putting them in the front of the line. That's exactly what we need to do in our trauma centers to fight this battle. It's very important that we have a very well-defined reversal strategy for those patients. And more importantly, they reduce their mortality from 37% to 10%. So this is an example of a great quality improvement process by people that are thoughtful about it. Well, when we thought that was the end of the story, it's not Viagra, but it's PRADAXA. So it's amazing to me that you can learn about these things reading Forbes magazine. But there was this article in Forbes magazine saying, names you need to know, PRADAXA and Xarelto. So PRADAXA is one of the new kids on the block. Is an oral direct thrombin inhibitor used for atrial fibrillation. Good study done by the cardiologists. They say it's a great drug, much better than warfarin, because you give it, it works. And if you give more, it works more. And if you give a higher dose, it works even better. And you don't need to monitor. So, yeah, just give it. You don't know what the heck you're doing and hope for the best. The problem is that there is no specific antidote, and we don't know how to reverse it. So this is what it says. The bioavailability after you take a pill is 3 to 7%. Most of the drug that's bioavailable is cleared by the kidneys. So one way to reverse is dialyze everybody, which is not very easy to do in trauma patients. And again, it doesn't require routine coagulation monitoring, and there are no dietary restrictions. And the half-life is 12 to 17 hours. So if you stop it now, start praying for the next 12 to 17 hours. What is written in the product insert? I love to read those things because this is amazing. There is no antidote to dabigatran. Now, in the event of hemorrhagic complications, this is what's it's written there, believe me. Initiate appropriate clinical support. What the heck is that? Discontinue treatment. That's great. Investigate the source of bleeding. That's a good one. Dabigatran is primarily excreted in the urine. Therefore, maintain adequate diuresis. Well, if people are bleeding, that's what we try to do. Can be dialyzed. Well, not very easy to do for us in trauma. Consider surgical hemostasis. Well, if people are bleeding to death, the only thing we can do is surgical hemostasis or the transfusion of fresh frozen plasma or red blood cells. Well, that helps, right? They didn't say call the priest. There is some experimental evidence that supports the use of prothrombin complex, and I'll go through this with you. And they also say consider giving platelets. Well, this inhibits thrombin. Why do you need to give platelets? Whatever. So this is to show to you that this is PRADAXA back there in the lower part of the slide, but there are new drugs that are being marketed currently that are as dangerous as thrombin inhibitors. The one that we are hearing more and more about is Xarelto. This is an oral factor 10A inhibitor. So PRADAXA inhibits thrombin, and Xarelto inhibits factor 10A. So this is being approved for prophylaxis of DVT, knee and hip replacement. There is no antidote and no monitoring required. Again, great. Half-life is 5 to 9 hours. So you're on your own for 5 to 9 hours because there is no way you can reverse this. But there is some studies showing that prothrombin complex concentrate may work. Now, these other 3 drugs are on the horizon. Apixaban is actually being marketed as we speak. And again, you will see that there is nothing you can do. So for reversal, for warfarin, we know what to do. For Xarelto, the suggestion is factor 7A PCC, and for dabigatran is factor 7A. But really, there are no studies, and you can see there are no comments about the effectiveness of the strategies that the company is proposing if in the case of hemorrhage. So we really don't know exactly what to do. So for those 2 new drugs, people suggest that if there is mild bleeding, you should stop or delay the next dose. That's fine. If there is moderate to severe bleeding, you need to do all those things that I just described that don't help very much. And if there is life-threatening bleeding, then people are talking about PCC as probably the only strategy, and perhaps in the case of dabigatran, PCC and or factor 7A as the only strategy that may help. So really, this adds a lot of confusion. This is data on Xarelto and PCC. As you can see, it works dropping the effect on anticoagulation, but if you look at the effect of PCC on dabigatran, it's very minimal. So even PCC may not work very well in those drugs. So here is an interesting chart that I want you to think about. Again, don't need to read this, but see there's blank here, there's empty here. So this is the new drug, apixaban. Here there is not applicable, blank, no published studies. This is dabigatran. Nobody knows. And there are a lot of recommendations for Xarelto, but the only one that's meaningful is PCC. So I really don't know exactly what the right thing to do is, but we got to prepare ourselves because our trauma centers will be inundated by those patients taking these new drugs that don't need monitoring. They are eventually a little cheaper than warfarin, and cardiologists love them. Now, I think there is light at the end of the tunnel. There are some drugs that are being worked out by industry that may help us. So there is a drug that's called factor 8 inhibitor bypassing activity. I told you FIBA. It's been approved now for warfarin reversal and as well as for this new reversal of those new drugs. There are some recombinant factor 10A that may help with the 10A specific inhibitors. There is an anti-thrombin variant that may be a good antidote for heparin derivatives, such as low molecular weight heparin. So we know how to reverse IV heparin, but we don't have a good antidote for low molecular weight heparin, and this might be it. And there are some engineered monoclonal antibodies in the work that may help, with the reversal of dabigatran, but that's in the experimental phase. So there is light at the end of the tunnel. I don't think it's bright enough to convince me that we know what to do, but we need to keep studying those things. So in conclusion, I think that there are several advantages of recombinant factor 7A and PCC over FFP and vitamin K. Time to reversal is critical. Those drugs are readily available, so we need to make sure that we have those drugs incorporated into our institutional protocols. And I believe that PCC has some potential advantages over factor 7A, but we still need comparative trials. Thank you very much for your attention.
We'll take a few questions if you have any, and then we'll do a very short little break as well. And while you're lining up for your questions, what I'd like to do is take an opportunity to just present Dr. Coimbra with a little token of appreciation for making the time to come out here. What you don't know is he normally charges by the hour, so that's why we loaded him with a couple of talks this afternoon.
So, Roy, on behalf of the Arizona Trauma and Acute Care Consortium, I'd like to present you with this plaque for giving our 4th annual Thomas Wachtel keynote address.
Thank you very much.
Thanks, Dr. Coimbra. Thank you.
Dr. Maxon, you have a question?
Well, that's a great talk. In our rural state with a large population of elderly patients far away from our metropolitan centers, should our air ambulance providers be carrying PCC or FIBRILLATION with them? Because plasma and platelets just aren't available at the community hospital.
Fantastic question. Todd, I'll tell you that we get 600 transfers from the desert area from the county next to ours, Imperial County in California, and they don't have the resources either. So the beauty of living an organized trauma system is that you can really affect what people that refer patients to you do. So we develop a protocol for San Diego County and Imperial County that all hospitals that refer patients to trauma centers, that are not designated levels 3 or 4, but are regional medical centers, they have to follow the Trauma Medic Audit Committee protocol. And what we tell them is that if they identify that the patient is taking warfarin or any of those drugs, if they need to get a head CT immediately, and they need to give prothrombin complex immediately and transfer as soon as possible. So I think the answer is yes, as long as you work this out under a protocol that you can measure the effectiveness of your protocol. For those hospitals, it's cheaper to pay for the PCC, which is fairly cheap compared to factor 7A or multiple units of plasma and et cetera.
Dr. Joseph?
Dr. Coimbra, thanks for a great talk. I had a question about 3 and 4 factor PCCs. You know, a lot of the European literature supports the 4 factors. There's only, most of the Profil 9 are the 3 factors. 1, have you had any experience with the 4 factor PCCs? And 2, why do you think there's such a lag to get the 4 factors here for us to use if the 3 factors are just as good?
Yeah, so I don't know why there is some resistance to approve 4 factors, but I can tell you that just recently the FDA approved Beriplex, which is a 4-factor prothrombin complex concentrate that's used in Europe that I showed in one of the papers in cardiac surgery, etc. And the beauty of Beriplex that people have worked it out in a way that they know exactly what the escalating dose strategy is based on initial INR. And that will be commercially available for us in the United States soon. The FDA just approved it. Our experience with PCC has been very good. Getting feedback from the neurosurgeons, and by measuring INR 30 minutes after you give it, you see a significant decrease. So we are using in patients that we take from the trauma center to the CT scanner, see the head bleed. If they need an immediate intervention, they get PCC immediately on their way to the operating room. And the neurosurgeons tell us at least that they see a significant difference in terms of bleeding as they open the skull and etc. Obviously, you need to monitor coagulation intraoperatively and continue with your reversal, either with second dose PCC or recombinant factor 7A or FFP and vitamin K. Alicia.
So great talk. I just want a comment and then a question. So my comment, so we're seeing a lot of PRADAXA, as everyone else is. And we've had a couple of really sad cases. One where we tried everything, including dialysis, and we just watched the patient who was only like 61 die. We actually took it a step further and talked to our cardiologists because they love PRADAXA, and they were shocked when we told them that people were dying. They were like, really? It's such a great drug. So one thing, we just have to get the word to at least the cardiologists in our environment. So my question to you is, have you had success with dialysis? Because we haven't.
No, we only have 2 patients that we dialyzed, so our N is 2. And they didn't die, but I don't know if it made a huge difference. These were sick people in the ICU, with multitude of other injuries. So we did it because we didn't know what else we could do, quite frankly. We looked at pulmonary contusions blossoming, we looked at lower extremity hematomas getting bigger, and we didn't know what to do, so we decided to dialyze. But I think for PRADAXA and the other factor 10A inhibitors and new drugs, I think the strategy that will work is the same one that has worked for warfarin. Identify them early, put them in the front of the line, imaging them quickly, and whatever you decide to do to reverse, do it fast. Sandro,
so Raul,
you're going to ask me about TAG?
No question about TAG. Actually, I really enjoyed it. It was an excellent presentation as usual.
Thank you.
And Raul, I think, again, one comment, one question. One comment is, you said this, but I would just emphasize that. The difference between PCC and plasma is volume 2. You're dealing with the patients that are old, are elderly. You give 4 units of PCC, you give 8 units of PCC. As you showed, 8 units is 2.5 liters. And all of a sudden, the patient in the ICU being ventilated with acute lung injury. Difference of PCC is 20 mLs, infused quickly, small volume. You don't see transfusion-associated circulatory overload. You said that, I think that's very important. So my question is, so what do you tell? I got this question here, actually, when I finish. A surgeon, I didn't see that. There he is. So what do I do with the bigger trend? He has a patient with a bigger trend. So what does he do? What do you tell your residents and fellows to do when a patient with a bigger trend comes in, a bleed in the brain?
So again, protocol-based strategy, right? Image them quickly. If they have an intracerebral hemorrhage, today in our institution they get PCC, although the data is not very strong, because there is nothing else we can do. If they have a life-threatening hemorrhage that cannot be managed surgically, then dialysis may be a strategy to consider. Now, if they need to go from the CT scanner to the operating room, there is no question that we would give them PCC for a craniotomy.
Thank you very much. What we'll do here at this stage is we're going to take a very quick little short break. You can have you come back, and that's just enough time for you to go to the bathroom, talk to our vendors, and we'll see you back in 15 minutes. Thank you very much.